All righty. So, good morning again. We're back still in chapter 4, still dealing with the endocrine system. So, join me in chapter 4. We really only have one condition that we really want to talk about, but it is probably one of the most prevalent and functional conditions out there. So I really want to make sure we cover it well. So in all honesty, we're going to cover diabetes out of 3 different books, but I'm going to try to simplify it so that you're not having to read all 3 books to get the information you need. So one thing that I did on Canvas was under chapter 4, the pages that will come out of this book, which is the clinical handbook. Remember this book, first semester? Some people, yeah, we remember. So I'm like, no, we forgot. That's going to have housed in it, I think pages 47, 48, hypoglycemic symptoms and signs. We'll cover those. I put those in the actual PowerPoint instead of just waiting to put them in the book. So you don't have to go through the book. It's already loaded, and then I type the information into the PowerPoint, so you'll know that information as well with signs and symptoms. And this book gives us some as well. Our textbook gives us general signs and symptoms, whereas this one gives us signs and symptoms dealing with hypo or hyperglycemia. So their signs and symptoms are going to be, the ones in this book are worst case scenario in table 4.3 on page 155. These are the general signs and symptoms you'll see if somebody has either hypo or hyperglycemia. So, but we type those into the lecture as well. So let's start going back through it, and we'll try to cover it as best we can, and then I'll formulate out of that the book that I asked you to grab, because it's going to help us in just a few minutes. So remember, we're talking about endocrine dysfunctions with the pancreas, and we talked about diabetes mellitus. Again, it is a chronic disorder dealing with carbohydrate, fat, and protein metabolism. And the most important thing, it has dysfunctions as it relates to insulin, which is produced by the pancreas. So something is going wrong with the pancreas, potentially. So it's a pancreatic issue. Let's start with that. Okay, so we have 2 main types. There's multiple. Remember, there's a diabetes insipidus, and there's also a gestational diabetes. Diabetes insipidus does not have anything to do with the pancreas, but it is named diabetes insipidus. Gestational is similar to these 2 conditions, but it is pregnancy specific. So, but these are the 2 main types, if one would say. Type 1 diabetes or juvenile diabetes is when there's a lack, when the pancreas is either not functioning correctly, meaning it's not producing insulin at all, or it's producing very low levels of insulin. So it's either not producing at all, or it's producing very, very low levels. And now I need to supplement insulin because I'm not producing enough. So the problem with this one is I need to supplement insulin because I'm not producing enough. Again, it has the early onset. It's juvenile. Most people will know that they have a diagnosis with type 1 diabetes in their youth to teens. So even though it has 30s, most people will know that something is wrong in their youth and their teens, because they'll have issues with diabetes, where, I mean, not that people will be giving them blood tests, but they'll have some of the general signs and symptoms. Low blood sugar signs and symptoms, weakness, nausea, lethargy or lethargic, needing to increase their blood sugar. So they'll have hypoglycemic issues very early. Type 2 diabetes is called insulin resistance or adult onset diabetes. This is diabetes that is diagnosed from a patient who had a normally working pancreas originally. They had a normal working pancreas. The pancreas was producing a normal amount of insulin to help to break down the glucose that's floating in the blood. They had enough insulin and enough functional pancreatic function to do it. But due to excessive consumption, too much intake of foods that have glucose in them, sugary foods, high carbohydrate foods, processed foods, things like that, what's happening is they're intaking more glucose than their pancreas can produce enough insulin to break down. So I'm overworking the system, and now the system has a breakdown, and now that causes type 2 diabetes. As it says here on the slide, some of their pancreatic function will remain, but the pancreas is going to start breaking down in its function because it can't produce enough insulin to overcompensate for a bad diet and poor activity. So it's diet plus activity. Remember, we said your muscles, the cells of your body, your muscle cells have insulin receptors, or not insulin, they have glucose receptors connected to them, and physical activity causes them to pull glucose out of the bloodstream and use it on those glucose receptors on your muscles. So it helps to regulate blood sugar as well doing physical activity. So physical activity plus dietary consumption helps to regulate type 2 diabetes, because those receptors housed on the muscles when we're doing physical activity pulls in that free glucose and helps to use it as fuel. So it prefers glucose as a fuel, just not too much of it. Okay. So we talked about pre-diabetes being a risk factor for progression to type 2 diabetes. It is monitored daily using a glucometer or glucose meter. This is a little bit new stuff that we haven't talked about. There are three main ways, and really there's four, but there's three primary ways in which we can observe to find if a person has type 1 or type 2 diabetes. So this isn't in your book, but it's great information to know, so your patients will know what's going on, because chances are they're going to come into the clinic and they will have already checked their glucose that morning, and they should have a number to report to you when you're seeing them, or there'll be a glucose number on the chart, and that will determine if this patient is contraindicated from receiving therapeutic intervention that day. So these are confirmation tests, and we'll talk about number 4 is just a general test. So one confirmation test is called a fasting plasma glucose test or fasting blood glucose test. Some people call it fasting blood sugar test. So it's done 8 hours after the patient has last intaken food. So they'll be put on an intermittent fast for 8 hours, and then they will check their glucose levels to see how they're doing. If their glucose measures greater than 125 milligrams per deciliter, then they will have a positive diagnosis of diabetes. Anything over 100 gives you a diagnosis of prediabetes. So 100 to 124, prediabetes. 125 or over, actual diabetes. It should be 100 or less, or it really should be less than 100. So normal on that test, less than 100. Pre-diabetes, 100 to about 124. Actual diabetes, 125 or greater, with a fasting blood glucose or a fasting plasma glucose test. So that's one way they'll check it. They can do an oral testing, have a person drink something sugary, like a soda or something like that, and then wait 2 hours and measure it. If it's going to be positive if the patient has a blood glucose level of 200 milligrams per deciliter or higher. Normal should be anywhere less than 140. Or they can do an A1C test. This is an actual blood test where they draw your blood and they measure the A1C within your blood, which is attached to your hemoglobin. So they're measuring the hemoglobin. And this is going to be a test that looks at the prolonged history. So it's going to look at your blood sampling over the last 2 to 3 months. So even if a person has, cutting down on the sugar in the last couple of days, just trying to fool the doctor, they'll take an A1C and that gives them a prolonged history. And it's a positive test if their A1C is 6.5 or greater. So you'll see these tests for all of these different drugs that are out now, and people are on there bragging about, my A1C fell within this range, or my A1C dropped by this much. I think the newest drug that they're using to treat this is also a weight loss drug that people are big on. Ozempic, if you may or may not have heard of it, there's some people, it's a drug on the market. Its primary purpose on the market, it was FDA tested to be a diabetes drug, a drug that helped to lower blood glucose, but they also found that it had a secondary effect as an adequate appetite suppressant. So now they'll prescribe Ozempic, even though it is a drug that's primarily should be given for diabetes, they'll also give it for people who are looking for weight loss. So you'll see these Ozempic commercials. Most people are, like I said, using it for weight loss, but it is a drug that's primarily supposed to be given for treatment with diabetes. Now, they're both one and the same. The larger your body mass becomes, the more your body can experience something called insulin resistance. So that's how body weight plays a role in developing type 2 diabetes. The larger your body mass, the more you develop what's called insulin resistance. The more insulin resistant you become, the more there's free glucose in your system, which adds to your body weight. So you see how it's a continual cycle? One is going to cause the other one, and the other one continues to trigger the other one. So they're constantly triggering each other. So that's why it's one of the things. Another one they can do, and that's the one that most patients will do, they will do just a simple a glucose monitoring test where they'll either do the finger stick and put it on a glucometer, and it'll give them a general number. So it will spit out just a number just of where they are at the moment. Same way, it should be less than 200 milligrams per deciliter on just a general test as well. Yes, ma'am.
So the A1C test is, you're able to test like 2 to 3 months, and then is that like, you're testing how much sugar, blood sugar's in the body?
Right, you're testing, it's a measurement of the hemoglobin. So they're looking at the actual hemoglobin, which deals with your oxygen, your osmolality of your oxygen. It's a whole lot of headache, but it deals more with oxygen content, and they're measuring the amount that may be attached to the hemoglobin. So it can bind to even hemoglobin. Mm-hmm. Okay. So, so that's some of the. So these are signs and symptoms. Now going back to the book, these are the ones from that book there that are also relevant. So let's blend some of these together. So in the book here, the actual textbook, page 154, it says the functional pancreas' job is to secrete insulin and maintain glucose levels within a precise range. Insulin normally reduces glucose level by transporting glucose into the cells for use as energy and storage as glycogen. So glucose's job is to give us energy. So your body likes it. A reduction in insulin can lead to hyperglycemia and deprive the cells. The cells can begin to metabolize fat and proteins instead of metabolizing their normal carbohydrates, and that can lead you into ketosis or ketoacidosis. The danger of your body continually processing fat and protein versus carbohydrates is it leads you into something called ketoacidosis. 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 So what is ketoacidosis? I'm glad you asked. So here is an overview of what ketoacidosis is. So it occurs when we don't have enough glucose. We don't have enough insulin in the body. And so what happens is our body starts to break down fat and carbohydrates, and it produces acids in our bloodstream called ketones. So our blood becomes more acidic, which can lead to us developing something called sepsis. Okay? So this breaks down our body. So it's not good. So even for people, if you have friends who are big into keto diets, they're, man, I'm keto. I lost so much weight. I lost 75 pounds of keto. It's all I eat now. I'm eating bread. I don't eat anything but fats and bacon and fats and protein and chicken all day long. Chicken and fat and protein. It's all I eat. And man, I lost a lot of weight. You go, high five, good job. You're going to go into ketoacidosis and probably become septic and die. It's not a good way for the body to live. The body relies on carbohydrates as a functional source to live. So I'm not saying this as a joke, but I know a lot of people who brag about being on keto, and yes, you do lose a lot of weight because carbohydrates can be stored as fat. But there are some healthy carbohydrates, fruits, vegetables, those are healthy carbohydrates. You don't have to just eat chicken and bacon every day, pork rinds. I've heard people have all kind of weird diets. that's dangerous. Can you imagine it? I can eat all the butter and mayonnaise I want. That sound normal to you? Yeah, trust me, it works. I lost a lot of weight. Okay, sure. Good stuff. So, ketoacidosis, that's the danger with this, and the same danger with having being on a keto diet. Okay. We talked about with hyperglycemia, there are three things that a patient usually would develop: polyuria, polydipsia, and polyphagia. Polyuria, polydipsia, polyphagia. Polyuria is excessive urination. Polydipsia is excessive thirst. Polyphagia is extreme hunger that's outside of the context of just being hungry. Okay. Okay. So those are things that people will develop: polyuria, polydipsia, polyphagia. Okay. So here are, if a person has moved into not just being pre-diabetic, but into hyperglycemia. So let's give you that terminology. So for me to be termed hyperglycemic, or to have a diagnosis of diabetes mellitus, I will have to have at least one of those three tests that are positive, but primarily the one is the general blood sugar, not where a patient's blood sugar or their A1C. But if they look at their blood sugar, anytime you have a blood sugar of 200 milligrams per deciliter or over, at any time you are now hyperglycemic. Anytime you have a blood sugar less than 70 milligrams per deciliter, you are now in what we call hypoglycemia. Hypoglycemia. Okay. Good stuff. Good stuff. Okay. So these are some of the symptoms. Don't try to learn all of these. Just kind of familiarize yourself in general with some of the symptoms that you would see if a patient has these, because you'll see these specifically if you work in outpatient. Patients are going to come in with these symptoms, and you're going to want to know, oh, this may be something weird. Extreme thirst and frequent urination and increased appetite are a big one for hyperglycemia. Then the blurred vision, the nausea and the dizziness can kind of go to it as well. Hypo, you'll see the sweating, the weakness. There are complaints of headaches and fatigue, impaired vision. They can't see straight. They're walking weird. They may be hypoglycemic. We'll talk about foot ulcers. Okay. So type 1 diabetes, if we're treating it, it's going to require insulin replacement. We are not producing enough, or the pancreas is not functioning at all. So we need to replace it. So that's when we talked about insulin pump therapy, actually using an insulin pump. I need to supplement what my body does not make. So I need to supplement what my body does not make. So I need an insulin pump. Okay. So that's when we do insulin pumps. Type 2 diabetes is usually monitored with three things. One, increased physical activity, because that's going to pull some of that free floating glucose out of the bloodstream, physical activity. Number two, reduction of glucose in the diet. So cutting out all the sugar stuff. Not saying you can't have carbs, but all the simple processed sugar, sodas, cupcakes, cookies, pie, all of that type of stuff. The really simple sugar, they're really not simple, they're complex sugars. Multiple chain sugars, cutting that out. They're still allowed to have some basic simple sugars, but it still needs to be monitored by an endocrinologist. Really a good endocrinologist who is treating a type 2 diabetic will give them a diet that they should follow on a daily and weekly basis and monthly. Like they'll give you a diet that you should follow all the way out to the month. They'll tell you, you want to shoot for foods that have very low levels of glucose in them. They should have some, but you want to stay within a certain glucose range. When you're reading the labels on the back of your food, it says it has this many grams of sugar. They have a certain number that the person needs to stay in so that that number matches the amount of insulin that their pancreas either can already produce or what they can supplement in to help it to control. So they'll have numbers. They'll be, you only can eat, 20 grams of sugar in a day. So you have to watch what you eat. Just look on the back of the package. 54 grams. And it's a lot of sugar and a lot of stuff you wouldn't even imagine it's in. Juice is terrible. Like apple juice, orange juice, stuff like that. Terrible. It's in a lot of stuff that you wouldn't think sugar was housed in. So that's number two way, and then supplementing insulin to assist if needed. Patient needs to be educated to recognize symptoms of diabetic coma or diabetic shock or insulin shock or insulin reaction. That's table 4.3. If a patient going into a diabetic coma is a patient who has too high blood sugar or too low. I'll never forget, I was talking to someone, I was working here at the time, but they were working at a hospital. It's not the one I normally work at, but they were working at a hospital, and the patient came in, and they're a nurse. So it was one of my buddies, like, man, we ran a glucose, we did a glucometer test on a patient. It's like, you wouldn't believe what their blood sugar popped. And I was like, was it hyperglycemia? It's like, yeah. It's like, oh man, probably 280, 300. I've heard of people popping 300, 320. He said, man, this fella popped 600 on a glucometer test. That is that is 1 foot in the grave and the other foot on a banana peel, near death. It's like, how in the devil do you pop 600? I didn't even know that was a number you could reach. It's like, yeah, pop 600. So people can have too high or too low. So some people, and sometimes people can end up with hypoglycemia because they start to make changes. So they can be a type 2, they can have been diagnosed with type 2 diabetes. They're making those changes. They're eating better. They're more physical activities, changing up everything, and they're still doing insulin. So the activity plus The eating better has lowered their glucose number in general, but now you're adding more insulin on top of that, and it's breaking down even more of the glucose in the blood, and now they go hypoglycemic. Does that make sense? So you can break down too much sugar. The body needs some of it. Okay, so diabetic coma can be too high or too low. Insulin reaction is going to be excessively low blood sugar. So these are some significantly low numbers, way below 70. Treatment, we talked about this, sulfonylureas. These are oral medications that stimulate insulin production. Metformin is something you may see patients on. It prevents the liver from producing hepatic glucose, which helps enhance insulin. So it stops the liver from producing glucose, which now the insulin in your bloodstream has to eat up to consume. It now just produces from what you eat. Okay, so here are some functional interventions. These are things that you'll find on page 49 in that textbook, in the clinical handbook. These are some things you definitely want to know when you're dealing with patients. Number one, if you are in an acute care setting, these are things that will be on the chart. So even if the nurse forgets to mention it, your job is to do a chart review every time you walk into a room. So you need to chart review and see what their blood glucose is for that day. And there are some other labs we'll talk about as well, but glucose is a main one. If the level is less than 100 or more than 250, exercise is contraindicated. In general, you want patients to have eaten at least 2 hours before exercise. If planning to exercise after the meal, they should wait at least an hour. They should wait at least about an hour. During or after exercise, hypoglycemia can be managed with fast-acting carbohydrates. So if their blood sugar is starting to get low, they're in the gym, they're working out, like, ooh, I'm getting dizzy, starting to feel bad. I just feel like I need to sit down. My vision is starting to become weird, not blurred, just, visual changes. It's probably hypoglycemic, okay? So we would normally just run upstairs, go to the cafeteria, grab orange juice, give them peppermint. So we would always keep peppermint in the gym. That's a quick glucose boost as well. Honey is great as well. Okay, so that kind of takes you through diabetes. If you just want to get more understanding, in the new book, in the book like this, well, your book is the white one, like this. Page 466, 467 does a good job of walking you through diabetes as well. Mm-hmm. So that book talks about it as well. Does a good job of breaking it down. Then it also mentions it in the 500s, like 528, 529, somewhere in there as well. Yeah, somewhere in there. Okay. So that's diabetes in a nutshell. It is a significant diagnosis. Yeah. Any question? Gestational, we talked about that, is detected between 24 and 28 weeks of pregnancy. The patient may exhibit the usual signs of diabetes mellitus, polyuria, polydipsia, polyphagia, and then they'll have their routine blood and urine screenings performed, and that indicates excessive glucose. Okay, and we talked about that. Following up, they'll have some of the same things as well. For treatment, 158, treatment starts as soon as possible to preserve a healthy pregnancy. Medical management is similar to treatment for general diabetes, with close surveillance of the mother and the fetus because of the increased risk of complications. Controlling of the diet and limited limits on the intake of simple sugars. Consistent moderate exercise such as walking is encouraged, and oral hypoglycemics may be prescribed, or insulin if it's indicated. Okay. Okay. So for patient teachings, emphasize the importance of regular prenatal checkups. That's why those are so important, to help monitor weight, proper nutrition, and blood glucose levels. So those things can get out of whack pretty easily as well. And then hypoglycemia is abnormally low glucose, just kind of walking through some of the things we've talked about it. So it's a deficiency of glucose in the blood sugar. It occurs when there's excessive insulin entering the bloodstream, or when glucose release rates fall below the tissue demand. Symptoms, we've already gone through those. Because glucose is the primary fuel of the brain, the consequences of hypoglycemia can be severe. Extremely low levels can cause CNS manifestations, including confusion, visual disturbances, and behavior that may be mistaken for drunkenness, stupor, or coma. Okay. Okay. So the etiology, the major cause of drug-induced hypoglycemia is insulin overdose. So the patient either taking too much insulin, so I forgot to take my insulin yesterday, I'm gonna double up. Now you're in insulin overdose, passed out. Or like we were saying, making modifications to fix things that were wrong and still taking an insulin level that's too high for the level you're now at. Still is dangerous. Failure to eat a meal or excessive exercise also can trigger this in the insulin-dependent patient with diabetes. Okay. Sulfonylureas can induce hyperglycemia. That's the medication. Non-drug induced hypoglycemia can result from fasting. So people who, I'm an intermittent faster, I only eat 1 hour a day. Yeah, I'm on this thing. I'm on this real big kick. You know, everybody tells me you got to eat a lot. You know, only eat, you know, I fast for 23 hours a day. All kind of stuff out there people are doing that's crazy. You know, I only eat 2 hours a day. I fast 22 hours a day. Yeah, what? That's dangerous. So intermittent fasting can be a way that can cause hypoglycemia. Delayed or excessive secretion of insulin by the pancreas, gestational disorder, or heredity. Okay. Diagnosis is done. A glucometer can be used to take a quick screening test. Typically, fasting plasma glucose levels can be as low as 45 grams per deciliter after a period of fasting. The diagnosis of hypoglycemia is commonly defined as blood sugar less than 50 milligrams. So some places say 70. So if you've never seen it, let's see if we can't hunt down a glucometer test. We started early. I was like, why are we so far ahead? Okay, let's do that one. Maybe. Oh.
Online medical school.
They're changing the way the medical education.
Hi, my name's Simon. I'm one of the final year medical students. Can I just check your name and age, please?
Yeah, it's Andrew and I'm 25.
Nice to meet you, Andrew. So today I'd like to check a blood sugar reading, if that's okay. That'll involve me taking a small blood sample from the end of your fingertip. Does that sound all right?
Yeah, that's fine.
And could I just ask you to go and wash your hands quickly with some soap and water, please?
Okay.
Whilst you wash your hands, I'll just assemble my equipment. If you could just put your hand on the table for me, I'm going to take the blood sample now. So you might feel a sharp scratch.
Okay.
Okay. Sharp scratch. Just pinch your finger together for me. Okay, Andrew, that completes the procedure. Thank you very much.
Thank you.
So that's what it is. Just a finger stick that leads to a glucometer test. So it's not bad. So we don't normally do these. These will be done. Nursing does this a lot with patients when they come in. We rarely ever do glucometer testing. I don't know if any therapeutic clinics. Any of you see that while you were in clinical? Anybody doing glucometer testing? I don't know if it's contraindicated that we can't do it. I don't know if it's just something we do or don't do. Okay. Let's run through metabolic syndrome and then we'll take a break. So metabolic syndrome, it's on page 158. It's in a little box up there at the top. It's called Syndrome X, and it's a collection of signs and conditions that together may increase your risk for having type 2 diabetes and cardiovascular syndrome or cardiovascular disease. So how does this work? So remember, if I have excessive amount of glucose in my system, it's going to manifest itself by increasing my body weight. So I'm going to become larger. As I'm becoming larger, my circulatory system has to work harder to circulate blood over my body versus what it was having to do when I wasn't a certain size. So not only are you reducing your abilities to break down insulin and causing type 2 diabetes, but it's also overworking the cardiovascular system, which can lead to heart failure. So, it has 5 main components: central obesity, which is fat around the waist, greater than 35 inches in women, greater than 40 inches in men; increased blood pressure, greater than 130/85 for men and women; high triglycerides, that's the amount of like the free floating fat that's in your blood, your triglycerides. Abnormal HDL, so you have 2 different types of lipoproteins that we deal with, HDL and LDL. So you want low HDL numbers and moderate LDL numbers. So that's a healthy thing. And we'll get to those when we get to lab values, don't worry. But just abnormally high triglyceride, a high HDL, so so abnormally high, HDL levels are high, yes. And you have a fasting blood glucose above 100. And that can lead to metabolic syndrome or syndrome X, which is not just diabetes, but it's potential leading to diabetes with cardiovascular effects. Because now we have the hypertension, the 130/85, which is hypertension, and the HDL and LDL and the triglycerides. So that's what makes it dangerous. Okay? Any question? All righty. Take a break. Let's take 5 from that. What time? We started at 10, so we have about another 20 minutes or so. Then we'll give you a break. Yeah, here we go. So again, peripheral neuropathy is one of the biggest dangers of developing diabetes. It is one of the mainstays of diabetes. It literally is just what it sounds like. Peripherally, your nerves don't conduct great sensory information. So imagine we talk about all the different sensory things that we send to the brain. Peripheral neuropathy inhibits your body from sending sensory information. So it limits neuropathy. So they'll have motor function, just no sensory. And it won't be coming from the spinal cord or from the brain. It's coming from the distal receptors. And so they can't pick up sensory. So these will be people who will come into their doctor's office. They'll have peripheral neuropathy. It's in what's called the stocking glove. It's in a stocking glove format. That's from chapter 3, I think. We talked about stocking glove a little bit. Chapter 3. That's where the person, literally, it's like they're wearing gloves that prevent. So anybody here ever wear like big winter gloves? You've been out in the snow skiing, maybe a couple people, big ones. So imagine trying to feel things with big rubber gloves on, or big rubber boots. You can't feel anything. So that's the way peripheral neuropathy feels like. They can't feel anything. It kills those distal receptors. And so it prevents it from sending information to the brain. So they'll usually be mandated to see a podiatrist. They'll come into their physician's office with toys or all kind of stuff stuck in their feet, and they don't even feel it because peripheral neuropathy has killed those distal sensory receptors. So that's one of the big ones. Diabetic ulcers, where it decreases blood flow, and that can lead to amputations. So a lot of times these patients will end up with amputated limbs, lower extremities, things like that. So it is a real condition that needs to be managed. Any questions? Any day now. No questions? Either I explained it well or your brains have totally shut off because you took a test. There we go. 1 or 2 people are honest. I'll take it. Hang in here with us. We shall finish. Or better yet, call it a morning. We'll do it later.